This is Dr. Artie Kavanaugh. I'm at RWCS 2020 and reporting on Room Now. My friend and colleague, Dr. Jack Cush, and I talked about advances in rheumatoid arthritis therapy. And boy, there's a ton of stuff this year. One very interesting thing, which I think is very practical, talked about chronotherapy, and that is when you give medications, and it was looking at nonsteroidals. Now, this was an animal model, it was in mice, and rodents are active at night and inactive and sleeping in the day. And the cytokine profiles and the cell mechanisms are different. In the active times, it tends to be more inflammatory, whereas in resting times, it tends to be more biased toward tissue repair. And what they're able to show in an elegant series of experiments was that nonsteroidal, they gave them the equivalent of ibuprofen, if you administered it during the active time, was anti-inflammatory. If you administered nonsteroidal during the resting time, it actually impaired wound healing. So I think we tend not to think about dosing in terms of the times, but I think this is a message that I'm going to bring to my patients and tell them that maybe nonsteroidals, especially short-acting ones, should be used during the most active times of the day. There's a lot this year on study designs and study interpretations. One design issue which we thought was interesting was a metric that we haven't really seen a lot in rheumatology, and that is patients getting worse. And this is very important in the clinic when patients are switching from one therapy to another. One of the first things to ask is, am I going to get worse? It'd be great if I was better, but I don't want to get worse. And there was this analysis of the sarilumab adalimumab monarch study where the patients were switched. Everybody was given sarilumab or adalimumab, and then the adalimumab patients switched to sarilumab, but they didn't know which they were on. And Jeff Curtis presented this at the American College of Rheumatology. They looked at people who were in between, who weren't fantastic responders or non-responders, but those with some response, and followed them and said, did they lose response? Did they get worse as a result of switching? And they had a beautiful control. They had the control of switching from the adalimumab to sarilumab versus staying on the sarilumab. Turns out, by different metrics, and we don't have a standard for worsening, but if you look at the CDI change greater than 6 or greater than 12, not many people worsen. And I think I'd love to see this metric and analysis in other studies in rheumatoid arthritis. And lastly, there's been some interest this year looking at the trajectory of response. So using machine learning and just analyzing how well people do over time. You have a group of people get really a lot better very fast. Those are great. You have people who don't respond. And then you have people in the middle. And I think we need to look at this a little bit more. I think speed of response is something we see in the clinic. Some people do better really fast, some people don't, some people it takes longer. How long do we wait? This speaks to issues of treat to target. And I think this is something we're going to analyze more because it'd be great to predict who is going to respond with what degree of speed. So this is Dr. Artie Kavanaugh, RWCS 2020 for Room Now.